gynecologic sarcomas can be quite aggressive, but they also have a very broad range of how they behave. And so, what is your approach to the tumor and the sarcomas in the advanced or metastatic setting?
Sure. So the first thing we want to make sure is we have outstanding imaging, because we want to know before we make a surgical decision. We try our best to get the surgical extent of disease. So in a patient with metastatic disease, depending on how many sites of metastasis they have, because we do believe that surgery for sarcomas is an incredibly important part of our armamentarium to treat these tumors. So we would look to see, is this person going to be able to get surgically resected to almost no residual disease? A lot of the studies that have looked at this have looked at patients that are kind of reduced to R0 or minimal residual disease, because that will just help the chemotherapy work better for the microscopic disease that we don't see.
We've seen that with lung metastectomies as well, right?
Absolutely.
Even if there's upwards of 8 to 10, you can take them out.
Sure.
They actually live longer.
Sure.
And better.
So we look at that, and then we look at, is this patient going to tolerate a very big surgery? For example, if they have a metastatic uterine leiomyosarcoma and they've got an omental metastasis and maybe an isolated metastasis to the liver, if we can surgically debulk all of that, then, and it's in a recurrent setting and they've had a long progression-free survival, that might be the patient to do surgery in. But we want to make sure that they're healthy, they have a good performance status, that they're going to be able to tolerate a long surgery, they're going to be able to tolerate a large blood loss, because oftentimes sarcoma surgery tends to be very bloody. So we want to make sure that they're going to be able to tolerate all of those things, because we're not doing them any services if they have a huge blood loss, end up in renal failure, end up in the ICU and can't get chemotherapy, which is ultimately what is going to help them. So I think that it's very important to look at all those factors when deciding if surgery is the right approach. For example, we had a case about 1.5 years ago of a sarcoma that looked quite adherent to the aorta. It was actually a retroperitoneal sarcoma, we think extending from the uterus, and we elected not to do surgery because we didn't think that we could safely approach that patient.
And I think you mentioned the thing about aggressiveness, right? I think that's a multifactorial equation to a certain degree of aggressiveness. So first off, you have how is the tumor behaving, right?
Sure.
And that largely part, I think, takes into account the grade.
Sure.
Right? So the grade, looking under the microscope, how many cells are dividing, how
Absolutely.
much necrosis is there, how weird does it look compared to normal cells? And so I think that grade is kind of a double-edged sword. Some tumors can be very aggressive, but also be more responsive to chemotherapies.
Sure.
And so, whereas if you have even a moderately aggressive tumor, but if it's not responsive to any therapies, it makes our job a bit more difficult.
Sure,
right?
absolutely.
So if I had a patient who was in really bad shape, had a very poor performance status, but if that was caused by the tumor and it was likely to respond, I would be pretty aggressive with
Sure.
it, right? Now, it changes the equation if someone comes in, they have a lot of different medical comorbidities. And you're not sure if they would be able to tolerate therapy.
Right.
That really is where my approach is really, I talk to the patient about a balance, right?
Absolutely.
There's the balance between toxicity and aka quality of life.
Absolutely.
Versus tumor control / length of life, right? And every patient is different. And so oftentimes I will see patients that are already metastatic, that are not surgical candidates, and where surgery wouldn't make sense for them. Though we can get to that point if they have responses. And that balance is different for every person. And so what is your discussion with patients about how aggressive you can be and what you would do for them based on what their values are and what their performance status is?
Right. And I think you bring up probably the most important point in this conversation is we have to be realistic with our patients. In a widely metastatic sarcoma, we are, probably not going for cure in those patients. We're going for extending quality of life, but and as well as quantity as well, and we want to make sure that we're not harming our patients. So I think it's important to really sit down with our patients, discuss, what are really the pros and cons of a surgical approach. One thing that often comes up in my discussions with patients is the creation of an ostomy, either a urostomy or a colostomy, because there are some people that in their minds, they don't want to have that. It's quality of life issue, and that's not for me to decide or for you to decide, it's for the patient to decide. And so we just present all of those options, and we say, if we do this and we're able to get all of it out, you have a very mitotically active sarcoma. It will likely respond to chemo, afterwards. This is something we think would benefit you with these possible side effects, surgically. And so I think that that's kind of that balance, exactly as you said, with kind of talking about side effects / results of surgery versus how much quality we're giving our patients.
I'm not sure if you see this as well as I do. I'm sure you do. Patients come in and say, what are my chances? Doc?
Right.
Right. What are my chances? What's the percentages? The problem is, and what I tell them is that, look, individuals are binary, 0 or 100%.
Right.
There's no in between.
Right.
And so we won't know until you try it, right?
Right.
And so oftentimes what I say, if they're really worried about the side effects of chemotherapy, I say, well, look, it's important to see how you tolerate that.
Sure.
Because I've seen some people in their 80s that do great with chemotherapy.
Absolutely.
No problems. And I also see people in their 30s that have a horrible time with it.
Right.
But that's, that comes into the conversation quite a bit. And I think, as you're right, I mean, it's really important to be honest with your patients so they can prepare and understand what the stakes are and what's important to them, so we can understand that.
Absolutely.